Good morning. Today's video is going to be about chest pain protocol. In the ER, chest pain protocol is something it's something we tend to see a lot of just because everyone comes in with either chest pain or shortness of breath. And so we have a certain protocol, at least based on the hospital I work at, to determine is this legit, is this not legit. And so there's a couple of things to go through for that, and so we're going to get into that right now. First off, for chest pain protocol, biggest thing before you do anything else, get an EKG. A 12 lead EKG. First thing you do. In my hospital, we like to get, from the moment they start signing in with chest pain, you have 10 minutes from the moment they sign in to get an EKG and get the doctor to sign it. Because if something comes back on the EKG showing a STEMI, then STEMI protocol, and you gotta call cath lab, IVs, heparin, Lovenox, all this stuff for STEMI protocol. So that's why someone signs with chest pain, 10 minutes to get an EKG. If it's normal, fine, that's good. Just means that when they get back to the back, that it's not a rush, they gonna die situation. And second, after the EKG, is blood work. STEMIs, but STEMI is basically ST elevation on EKG. So if they have ST elevation on EKG, then they're going to get blood work, but they're going to be more concerned with getting IVs done, calling cath labs to get them to surgery in the cath lab, more so than, oh, let's see how elevated their troponin is. Because if they're having ST elevation, that's a here, now, this needs to be intervened on. So basically, if their EKG is normal, then they'll just go with the standard chest pain protocol by getting blood work, which is usually troponin, CBC, basic. They may get a magnesium level also, but biggest thing is the troponin. And yeah, so the troponin. The troponin's elevated. It can mean a couple things. It can mean they either already have long-term damage from previous heart attacks, or this is something new occurring, or something new that has already occurred, even if the EKG looks normal. So, at my hospital, we like to get, if we really don't like to set chest pains out in the lobby after we triage them, but if it's chest pain caused by coffee, like a pleuritic chest pain, then we'll go ahead and get lab work from triage and then set them in one of these little side rooms. But normally if they're coming in with chest pain and it's not a STEMI, so no ST elevation, they usually get back to the back within 15-20 minutes, and usually they have to have an IV. You usually get blood work. Troponin is the biggest one, and they may be here for a couple hours, because if that first troponin is normal and they're not symptomatic, they're not having any other chest pain, no dizziness, no nausea, vomiting, everything else is normal, they may do a second troponin and a second EKG at the 2-hour mark. And if that's normal, they may discharge them. Otherwise, if they don't have any other risk factors, then they'll admit them. At least that's how it is at the hospital I work at. Third thing would be the interventions. If someone comes in with chest pain, and it's not pleuritic or cough-related chest pain, what do you do? One of the things you do is, in nursing school, they tell you about Mona, morphine, oxygen, nitroglycerin, aspirin. For the most part, we still do that, but lately some of our ER doctors are saying it's not evidence-based practice to do Mona anymore. More so the oxygen part, because studies have shown that we are over-oxygenating our patients. So, yes, you want oxygen to get to the heart, but you want to do so by opening up vessels instead of really giving them extra oxygen, if that makes sense. But you're going to still give that aspirin, the nitroglycerin, morphine. You're still going to do all those, because all those open up blood vessels to get blood pumping to the heart. So you're still going to do those, and you're going to make sure they're on the cardiac monitor. If they come in with chest pain, that's not cough related, please hook them up to the cardiac monitor. If not for anything else, to protect your license. Because if something were to happen to this chest pain patient and they weren't hooked up on a cardiac monitor, it's gonna fall back on the nurse. So, morphine, nitroglycerin, aspirin, cardiac monitor. And then, if EKG is normal, all the lab work is normal, the ER doctor may decide to still consult cardiology to see if they want to admit them. Otherwise, they may end up discharging them if they have a normal second EKG and a normal second troponin at the 2-hour mark. But if they have an elevated troponin, but the EKG is normal, then they're going to still consult cardiology, and that patient's probably going to get admitted. And that's basically chest pain protocol. It's not hard to figure out. It's just with chest pain protocol, you have to do stuff relatively quickly, just in case someone is having a STEMI. And that's kind of how we treat chest pains in the ER. It's like we're basically ruling out STEMIs. That's why we move so quickly for those. And I will talk to everyone in my next video. Hope y'all enjoyed this one. And I will see y'all in another one for another news talk about strokes next time. So, I'll talk to y'all later. Y'all have a good day. Bye.